Good afternoon, and thank you for standing by. All lines will be in listen only until the question and answer portion of the call. At that time, to ask a question, to press star, then 1, and please be sure to record your first and last name. Today's call is being recorded. If you have any objections, you may disconnect at this time. Dr. Henderson, you may now begin.
Good afternoon, everyone. My name is Jaquiba Henderson, and I'm an obstetrician gynecologist and medical epidemiologist in the Division of Reproductive Health at the Centers for Disease Control and Prevention. I lead the state-based Perinatal Quality Collaborative program here at CDC, and I would like to welcome you to the first presentation in a series of webinars we are sponsoring on Perinatal Quality Collaboratives. This webcast will present an overview of quality improvement in perinatal and maternal care, including information about the purpose, basic structure, and past successes of collaboratives. Our presenters today are Dr. Marilyn Kasika and Barbara Rose. Dr. Kasika is the Medical Director of the Division of Family Health within the New York State Department of Health. She provides leadership for New York State maternal and child health epidemiology and programs, health informatics, and quality improvement. She is a board-certified pediatrician with subspecialties in infectious diseases and preventive medicine. Dr. Kasika is a fellow of the American Academy of Pediatrics and a clinical associate professor of epidemiology at the State University of New York, University of Albany School of Public Health. Dr. Kasika has served in leadership roles in quality improvement initiatives dealing with asthma, school-based health centers, and the current New York State Perinatal Quality Collaborative. Barbara Rose is Program Director for the Ohio Perinatal Quality Collaborative. She has a master's degree in public health from St. Louis University, plus 30 years of experience in the fields of nursing, public health, physician practice, program management, and community-based health improvement. Her primary responsibilities include providing administrative oversight and leadership to a successful statewide perinatal collaborative to improve birth outcomes in Ohio. And more recently, she is a senior level manager and contributor to local community health improvement efforts, using data to make decisions around child well-being and measuring program outcomes. At the end of this presentation, you will have the opportunity to ask questions and participate in the discussion. The slides and audio from this presentation will be archived on our webpage at www.cdc.gov/reproductive health, that's /reproductive health /maternal infant health /PQC. I will now turn the presentation over to Dr. Marilyn Kasika and Barbara Rose.
Thank you, Kiba, and welcome everybody, and thanks for taking the time to listen to this presentation. At the end of this webinar, participants will be able to explain the need and purpose of perinatal quality collaboratives, understand how some collaboratives function and the basic structure of a collaborative. I think no two collaboratives are the same. And then discuss the successes that at least we have achieved, and I think that when you use this method, others have achieved success also. So I think everybody knows that in a collaborative structure, you have a lot of partners. And within the Perinatal Quality Collaborative, you have perinatal care providers, you have public health professionals, and the goal is to improve pregnancy outcomes for women and newborns. And you do this through advancing evidence-based clinical practices and processes. I think everyone's aware of the need for collaboratives to improve what we're doing. Preterm birth affects more than 500,000 babies, or 1 of every 8 infants born in the United States. It's the most frequent cause of infant death, and it's the leading cause of long-term neurological disabilities in children. And it is really costly to the U.S. healthcare system, costing more than $26 billion each year. Within our collaborative, we very early on organized around a mission, and our mission is to provide the best and safest care for women and infants in New York by preventing and minimizing harm through the translation of evidence-based practice guidelines to clinical practice. Good afternoon, everyone. This is Barbara Rose. I'm the director of the Ohio Perinatal Quality Collaborative, also known as OPQC. On the screen, you see the mission of OPQC. We started convening in 2007 and started our first collaborative in the middle of 2008. In Ohio, we have about 144,000 births a year, and our public partners, clinical providers, and data and quality improvement folks came together and with the understanding of wanting to use improvement methods to improve birth outcomes to all 144,000 births that we have each year in the state. So there's a lot of similarities among many state collaboratives. I just was in Chicago over the weekend at the Vermont-Oxford Network Congress. Many of you on the phone might be neonatal care providers, and many of the state collaboratives across the country have been started by either an interested, passionate neonatologist and or a maternal fetal medicine physician. At the moment, across the country, there are at least 17 states that have some form of organized state-level perinatal improvement. Ohio, New York, and California all currently have some funding from the CDC. And if I might just mention the other states that have a semblance of perinatal collaboratives: Colorado, Florida, Illinois, Indiana, Kentucky, Louisiana, Massachusetts, Michigan, Minnesota, Mississippi, New Jersey, North Carolina, Tennessee, Virginia, and Wisconsin. So pretty impressive. In Ohio and New York, the OB projects that we started with were reducing, at least in Ohio, we were reducing scheduled deliveries less than 39 weeks without a medical indication. And we're currently in a project looking at appropriate use of antenatal steroids for women who are at risk of delivering preterm between 24 weeks and 34 weeks gestation. Both New York and Ohio also have, actually, New York's Neonatal project is reducing central line-associated bloodstream infection, otherwise known as CLABSI. And in Ohio, we are actually reducing late onset infection in 22 to 29-week gestation infants. And then the second neonatal outcome in the New York project is reducing the percentage of newborns less than 31 weeks gestation that are discharged with below the 10th percentile of growth. Just to talk a little bit about the structure of the Ohio Perinatal Quality Collaborative, we have a blended funding model, and we have faculty from across the state. Our quality improvement lead is Carol Lannon at the University of Cincinnati, Cincinnati Children's Hospital. Our OB lead is Jay Imes at The Ohio State University, and our NEO lead is Michelle Wash at Rainbow Babies at Case Western in Cleveland. We also have regional clinical leads for both the OB project and the neonatal project, and we've worked really hard to make it a true representation of faculty and hospital practices across the state. The Ohio Department of Health has allocated a couple of different funding streams from state funds that then go through Ohio Medicaid to draw down some federal match dollars. We have a third-party administrator that manages those contracts and deliverables to us. We're delighted to be one of the 3 states that have a multi-year funding stream from the CDC. We have had several years of support from Ohio March of Dimes and National March of Dimes to continue our quality improvement education work across the state. And then we have a tremendous amount, actually difficult to calculate, of in-kind contributions from clinical staff across the state doing the work on the front lines, as well as many of our regional leaders who work either for very little compensation or actually devote their time to the project. So as far as in New York, we were a very different model of funding, and I think we began very much on a shoestring in that we had basically initially no state dollars, so it was mostly in-kind staff work, and we were working with our experts across the state who were very generous in contributing their time. And then we were able to identify some limited state dollars so that we could work on getting more of the quality improvement consultant work with us, as we are not experts, or were not experts when we began this project in 2010. We initially partnered with the National Initiative for Children's Health Care Quality, who during the first year really helped us with the model. And then we were very fortunate, as Barbara mentioned, to also receive the Centers for Disease Control and Prevention grant, which has helped immensely here in our organization and our ability to do our work. So I would say that, initially most of what we did was in kind. We were very supported by our partners across the state, and I think that was how we began our project. So this slide, I'm not going to, this is Barb, this slide sort of speaks for itself, but Ed Donovan was the founder of the Ohio Perinatal Quality Collaborative. Ed is a long-standing faculty member of the University of Cincinnati and neonatologist, one of the early physicians in the field, and he really brought together our public partners, the Medicaid and the Department of Health offices, as well as faculty and providers across the state, and really asked the question to find out how much interest and will there was in Ohio to develop a state-level perinatal collaborative, really population-based, and doing improvements focused toward all the births in the state. And lucky for us, many people in the room at that inaugural meeting stood up and said that they were indeed interested in being part of this, and that if we were going to improve perinatal outcomes in Ohio, that neonatology and obstetrics would need to work together on the mom and the baby dyad, and that was really a pretty big factor in how we first got organized in 2007 and 2008. We use the quality improvement methods. In Ohio, we use the IHI's model for improvement. And I have a couple of slides coming up just to document that. Many of you may use that or a variation of the model for improvement. Another key to helping practitioners improve care on the front line is regular measurement, data collection and measurement and feedback of individual site-specific data, and then also looking at the collaborative's aggregate data over time. We've had a number of publications over the years from our faculty leads, which we think just adds another measure of credibility in getting the word out in peer-reviewed journals, and have also had some coverage in the popular press around the work and the results that we've collectively achieved. And then lastly, for those of you who work in quality improvement, you know that sharing of the results, what did you do, what did you test, what worked, what didn't work, what are your results, is a key part to the learning and pushing toward improvement. Bit of a challenge when you're in the same geographic region and you might have hospitals who are in the same community working down the street from each other, and there's that sort of inborn competition, giving folks a little bit of hesitation sometimes to actually do transparent sharing. And I think in Ohio we've made some real progress in getting, not only our data sharing and multi-site confidentiality agreements, but just really folks working toward improving the population health outcome of births in the state. So both Ohio and New York have these multi-stakeholder networks that both Marilyn and I have outlined just a little bit. Many of the other states that I mentioned who have structured perinatal collaboratives use a similar stakeholder network model. We use the Institute for Healthcare Improvement's Breakthrough Series model. What do we want to accomplish? How will we know that a change is an improvement? And what changes can we make that will result in an improvement? And like I said, we track process and outcome measures, and both Marilyn and I have a few examples to show the viewers how we track those results over time. I think in addition to having the model for improvement, using the quality improvement science and feeding back data to the sites, we have monthly action period calls that have a fairly specific rigor to the structure. We always start those calls with the collaborative's aggregate data. We never share site-specific data unless a site has asked us to do so. And then periodically, usually once or twice a year, we have a face-to-face learning session, usually a day or a day and a half session where the OB teams and the Neo teams, that team being a physician, a nurse leader, an administrative or data person, come together and spend a day with us. We have group exercises, team time, usually some very focused plenary leaders participating, and that balance of monthly check-in calls and a periodic face-to-face really keeps people engaged, get them talking interpersonally about sharing their ideas and sharing the changes, and we've had some really good success with that.
So I'm going to just walk you through some of the things that we've done, and using, much the same methodology as Ohio, and I'm sure the other collaboratives across the country. But New York ranks 8th nationally in infant mortality and 22nd in premature births. And we have approximately 250,000 births a year, which is about the third largest in the nation. We have multiple focuses within our quality collaborative. We are focusing on the preterm deliveries. In the neonatal outcomes, we're focusing on enteral feeding and improving birth weight, discharge weight in infants born less than 31 weeks. And we're also working on reducing CLABC infections. So I think, Barbara alluded to this with how the Ohio Collaborative was established. And I think it's very important, and, one of the hardest things to do is to make sure that you have the right leadership on board to facilitate your work. We within the health department were very lucky to have buy-in with our executive leadership. But then, we had to reach out to our partners across the state, both in obstetrics and neonatology. And with neonatology, they were already engaged in a very active collaborative with the CLABC. However, this was new to the obstetricians. So we wanted to make sure, as we built the collaborative, that we were addressing all their concerns and that we were addressing the right issues when we went forward. So we established multiple expert work groups to advise us. So in focusing on the obstetrical project, these are the types of activities that we did with our experts. We had to formally define what a scheduled delivery was. And believe it or not, that took some time. And we had to also decide what was an appropriate indication, which took a lot of research and a lot of discussion as to what we would consider appropriate or for this project. We had to specify the sample size, and we are focusing on deliveries between 36 and less than 39 weeks. We decided it would be a monthly data submission, and we follow the improvement measures, and we do this through run charts, which you'll see an example of. So this is one of about 10 measures that we follow with our obstetrical initiative, and it's sort of a composite when we look at all scheduled deliveries without indication. And we began this project in 2010, like in the fall, so around September.
and we began with a rate of about 25% of deliveries without indication. And throughout time, you can see that now we're down to about 7 or 8%, and of course it fluctuates as all things do within a facility and human nature. So I think that, we've made some great progress in this measure. So just to summarize the collaborative that began in 2010, we followed about 6,000 deliveries, and about 60% of those were C-sections. And of scheduled deliveries without medical indication, we decreased scheduled deliveries by about 65%. We decreased inductions by about 70%. C-sections decreased by 64%. And we also looked at primary C-sections, and we've been able to decrease those by about 78%. We're also focusing on maternal education, and we've increased that by about 53%, 54%, although I think we still have a lot of work to do in that measure. For our next steps, we've been lucky that within New York State, there's a joint initiative with the Healthcare Association of New York and Greater New York Hospital Association, who received a CMS grant and have formed the New York State Partnership for Patients. And one of their focuses is reducing preterm birth. So we've been lucky enough to sort of merge with that project to become one as we roll out to all birthing hospitals in the state. So up to this date, we've recruited about 100 facilities, and that represents about 80% of the hospitals in the state who are now working on this project. To briefly talk about our enteral feeding project, the aim of this project was to reduce statewide the percentage of newborns less than 31 weeks gestational age that are discharged from a NICU below the 10th percentile. So the way this is a little bit different in that this is something that takes longer to achieve. So in looking at the measures and following what we can with the discharge weight, we're collecting data quarterly. So I think with any collaborative, you have to decide based on what you're measuring how you're going to approach the data collection and the reporting. And I think if you look at this, if you look at the top, that's data from 2009, and then the bottom is data from 2010. And this is a Fenton growth chart to follow preterm weight. And we're focusing on the mostly discharged to home. So in 2009, you can see that we have about 30% what we found of the hospitals were, of the infants were leaving less than the 10th percentile. And between 2009 and 2010, you can see that line shifting upward. And that was just, I think, a lot of it was follow-up, looking at the data. And people, because you're paying attention to the issue, things just seem to improve. So now we're in 2011, we're going to be looking to see if that line has improved even further. We began this project with our regional perinatal centers who have the biggest percentage of these preterm infants. And if you look at, on the left are the regional perinatal centers indicated by the letters, and then on the x-axis are the percent of the newborns that are discharged less than the 10th percentile. And I think you can see that there's a very wide range among these hospitals. The mean percent was about 32%, and you can see that some were doing very well with only about 12%, and then we have one outlier hospital that has about 60% of their infants going home less than the 10th percentile. Another way to look at this is, what is the risk of your infant if they're admitted to one of these facilities going home less than the 10th percentile? And there's about a 4.5 to 5-fold difference in risk between the best and the one with the hospital with the highest rate, ranging from about a risk of 0.4 to a risk of almost 2. So I think, there was a lot of work done to figure out what is the difference among these different hospitals, what can we work on to improve this. And we did a lot of very specific work, but what we found overall was that feeding practices and protocols varied within an RPC and among the RPCs. And I demonstrated, I showed you the risk of discharge for the discharge below the 10th percentile varied widely. We also saw that, simply having a protocol to initiate, advance, or evaluate feeding tolerance was not associated with growth, and that the risk of discharge weight less than the 10th percentile was lower with earlier first enteral and earlier full enteral feedings. And I know everyone is, whenever you talk about feeding these preterm infants, there's a worry about necrotizing enterocolitis. And we found that the risk of NEC was higher with later and longer trophic feeding and earlier introduction of fortifier. So we're still working on this, and I'm sure there will be more to come as far as this. What we're planning to do, of course, is to now look at the 2011 data to compare to 2010. We're also looking at head circumference, which we didn't initially have collected, but we thought was important to also look at. We're comparing practice and protocol usage between high and low performing RPCs to see if we can sort of identify some best practice. And as we mentioned, we want to share that so that we can improve the outcome for all the infants in the state. With our CLABSI reduction project, it began in 2007, and this was an effort of our regional perinatal centers initially to reduce CLABSI rates in their NICUs. And what they actually found was that the use of a checklist was very important to performance and outcome. And also on the left, if you would look at this, it was really important to have empowerment of the staff as a team so that no matter what role you played on the team, that it was equal. And if you saw something happening that should not be, you had every right to correct that no matter who was the offender. So I think having that empowerment really is important for a team to be successful. So to look at have we reduced CLABSI rates from the beginning in 2007 to 2010, the rate has gone from 4 central line associated bloodstream infections per 1,000 patient days to 1.6 in 2010, and we'll soon have 2011 data. So there was a 60% decline in this rate. So I think from this, as Barbara said, there are many publications, and Dr. Schulman was the lead on our publication on this, which identified and talked about the method and the use of a checklist. And what we're planning to do is now roll this project out to our level 3 nurseries in the state. These nurseries are already, of course, reporting to our healthcare acquired infection program, and their rates are higher than what our regional perinatal centers are. So I think we have an opportunity here to improve that also.
Thanks, Marilyn. So unfortunately, Ohio's numbers are not looking too good in terms of infant mortality and premature birth, so a lot of motivation to continue this improvement work at the population level. Talked a little bit before about the 3 main buckets of work, if you will, are the leadership and administration, the quality improvement, coaching and training, and the regular data reporting on a monthly basis at the site level, as well as the aggregate. And then I wanted to mention when we first started in 2008, our neonatal project was reducing late onset infection in 22 to 29 weekers. So in Ohio, we have 24 level 3, which is the highest level of NICUs in our state, that participated in the inaugural OPQC project, and that was representing almost 100% of all the 22 to 29 weekers across the state. And the OB project, the scheduled delivery is less than 39 weeks. We had 20 large maternity centers from across the state that signed up to participate. That represented about 47% of the births. So we had pretty good representation, and between the two projects, the NEO project and the OB project, we had 44 teams that signed up to be part of the inaugural group. We've been wonderfully successful in the first phase of the projects, and we've currently in 2012 ramped up to start a second phase of projects. For those 24 NICUs and the 22 to 29 weekers, when we first started, about 18% of those infants had a late onset infection, and we do use the VON, V-O-N, definition for infection. We saw a 20% decrease to about 14% of those babies. Still way more babies with infections than we wanted to see, so we've maintained that project and added a human milk as medicine component, which I'll talk about in just a minute. And the infection, we also have insertion bundle and a maintenance bundle for this project, and we see as the maintenance bundle reliability goes higher, the infection rate for this group starts to decrease noticeably. Related to the scheduled delivery project, we've again, because we look at this on a statewide basis, we have tracked a total of 6,000 fewer births a year happening at 36 to 38 weeks without medical indication, and I'll show you that birth certificate graph in just a moment. So for the 3 years that this initiative has been in place, that means 24,000 births have been shifted, resulting in almost 200 fewer near-term infants being admitted to the NICU, and a cost savings of about $11 million each year. These are the run charts. I'm not going to go into them at length, but the run chart on the right, which has lots of zigzag lines, is actually the VON measure of infection for our 24 participating sites, showing where we started at baseline was about 18%. We've gotten down to 14%, and with increased maintenance bundle reliability and these infants getting earlier initiation of human milk, we're starting to see the infection rate continue on a downward trend. The smaller graph to the left is the maintenance bundle. We do track an all or none maintenance bundle measure every month from our sites, and we're shooting for 100% reliability, and over the last couple of months we've been up in the 95% range, which is really encouraging. It means that folks are asking, does this line need to be in, and then doing all components of the maintenance bundle. And then the graph on the bottom with the red line and the small blue squares show the percent of infants that have had any human milk in the first 72 hours of life, and that's right in the 80% range. That collaborative has just been going since March, and we are looking to get that to up to 100%. That 100% of 22 to 29 weekers in our level 3 nurseries have some human milk, preferably mother's milk, by 72 hours of age. And our balancing measures for the human milk and infection project are looking at growth rate and then also NEC. I don't have any graphs of those yet, but both of those balancing measures are showing some promising results. It looks like the NEC rate for this group of patients is on its way down, and the low level of growth is actually lower than we expected. So stay tuned in another few months, and we should have some results that are ready for prime time on those two balancing measures. So our neonatology leader, Michelle Walsh from Rainbow Babies in Cleveland, these are a couple of quotes that she reminds the teams that line care by itself was not effective in reducing bloodstream infection, that both the safety techniques and the introduction of human milk early is what our key driver is leading us to do. And we also have a very strong underpinning principle that to continue to improve the birth outcomes, that OBs and the NEOs must work together. So Jay Imes is our OB leader. As I mentioned before, he's a maternal fetal medicine specialist from The Ohio State University. He led the 39-week scheduled delivery project, and now that same group of 20 providers, OB providers across the state started this spring quality improvement initiative to make sure that women who are eligible for antenatal steroids between 24 and 33 and 6-7 weeks gestation receive antenatal steroids before they deliver. And the bar graph on the right with the green and the red, when we started in October 2011, was just about 50-50. About half the women who were eligible got antenatal steroids, again, in this 20 hospital group. And about 50% didn't. And you can see since October 2011 to August 2012, which is the top bar on that, we're up to almost 80% of women getting a full course of ANCS. The blue bar is a partial course, and the red is no ANCS. So this particular group of practices is making progress on that. The next step for this will be to determine what elements of this bundle have been successful and take that out to the other maternity providers across the state. This is one of the graphs that OPQC is known for. We, in addition to site-specific data in both the neonatology project and the OB project, we use the Vermont-Oxford Network Infection as our population measure of improvement in the NEO project, and we use birth certificate data as our population measure in the 39 weeks project. This graph shows this is birth certificate data on a monthly basis. We've worked out an ongoing relationship with Ohio Department of Vital Statistics, and that we get monthly downloads of our electronic birth certificate data. The vertical line is where OPQC started in September 2008. The lower line is of the blue squares is the 36 to 38 week scheduled deliveries, and to the left of the vertical line you'll see baseline was pretty constant, not much change in the previous 24 months. OPQC as well as ACOG coming out with their 39-week statement again, and a fair amount of popular press picking up on the whole issue of scheduled deliveries, but OPQC also got its start then. Since OPQC started, the blue squares have consistently gone down, so 36 to 38 weeks scheduled deliveries without indication are on a decline, and the pink squares represent a shift in the 39 to 41 week deliveries. So, and there's a statistical difference in the change there. So the pink going up and the blue going down is statistically significant. And this is where that actually 26,000 births, where we say we're shifted from near term to full term, with a savings of about $24 to $26 million to the healthcare system over the last 3.5 years. So last December, when Ohio and New York and California had the opportunity to travel to Atlanta and meet with each other face-to-face with Kiba Henderson and her team and Dr. Bill Callahan, as we were getting into the funded work around state perinatal collaboratives, we had some great dialogue and exchange, and we're just really struck by how supportive the CDC is of this state perinatal collaborative work. And this quote from Dr. Callahan really caught our attention because one of the things that we are actively working on in Ohio is to improve the accuracy of birth certificate data. When we started using birth certificate data in 2008, people thought we were crazy. They said, how can you possibly use birth certificate data? Everybody knows that the quality is really inferior. And we believe that the more people used it and understood what it was being used for, that the quality would go up. And as we tracked birth certificate data, we also had site-specific data that we were comparing it to. And one of the very exciting deliverables that Ohio is working on for the CDC work is we did a number of site visits earlier this year when we went out to the smaller hospitals, or what we call our level 2, so a little bit smaller volume delivery hospitals, and met with not only clinical leaders, nurse managers, and the OB lead, but also with the birth certificate clerks. Tremendous amount of variation, as you can imagine, in who actually fills out the birth certificate at a hospital. The electronic version is due to the state within 10 days of the delivery, and there's also a lot of variation about where people look for the particular clinical information that fits that variable. So under development, hopefully in draft form by early 2013, are 5 online modules, each which will take about 20 minutes to complete, and those modules will be for any and all hospital staff across the state who enter birth certificate data into the IFIS system. Those modules will be: why is the birth certificate important to the health care of women and newborns? What are the variables in the Ohio birth certificate and what do they mean? Where are select birth certificate variables found in the medical record? How can I know if I have accurately entered data into IFIS, which is the electronic system? And then how can I improve the data entry processes at my hospital? So we believe that these online modules are one of the first of their kind in the country, and we will be testing them with some of our pilot sites in Ohio, and are really excited to take the next step. Another project that has been underway this year in 2012 is taking the lessons learned from the 39-week scheduled delivery project in the first 20 hospitals and taking it out to a new round of 15 maternity hospitals who were not at the table for the first phase. And that learning session was in March. Those 15 hospitals had the site visits. We're learning how to improve birth certificate data, as well as working with their clinical team about making sure that the birth certificate data that gets entered actually reflects the clinical practice at that institution. We're seeing some improvement in scheduled deliveries without medical indication. On the way down, the goal line there is less than 5% by birth certificate. And as an aggregate, this group of 15 hospitals is doing pretty well. I have to say that of that 15, there's about 2 that remain pretty significant outliers. And our clinical administrative team are working on some strategies to help the outliers. But again, this 15 really has helped us learn how to spread what works on the clinical side, as well as help understand the accuracy of the birth certificate data. This is just a published piece that we allocated a little bit of our CDC funding to go to Burness Communications to get the word out across the state about the value of the 39-week scheduled delivery project and to show some of those results. For those of you who may or may not be aware of Burness Communications, they're a large firm outside of Washington, D.C., and they do quite a bit of work with public health and nonprofits. They've been just terrific to work with, and this piece has gotten a fair amount of traction. This is our newest piece that we're really, really pleased with and are in the process of fine-tuning it. This is our second Burness piece, and this is actually geared towards parents and the public at about an 8th grade reading level. This is Human Milk as Medicine, and this is a patient education piece that talks about the value of human milk and how important it is. And when you unexpectedly deliver preterm, the best thing you can do for your baby is to express or pump breast milk for him or her. Talks about the 3 myths around pumping, and then we did feature a mom, an Ohio mom and preemie, who had a really good experience pumping for her little guy. So this is the piece as is from Burness. One of our sites is rewriting it at a 5th grade reading level for some of our moms who have a lower literacy level, and then we've just gotten the Spanish version from Burness, and I don't have a copy of that yet. So again, I think this is something that the content is evidence-based. It's got some color, it's got a family story, and really finding a lot of utility with this, just now getting it out to our sites are able to use the PDF and print it off as many as they want, and then we'll be probably posting some kind of version that doesn't have the OPQC logo on it. But happy to talk a little bit more about this. We're pretty proud of this piece. And so for next year, because we've got 144,000 births and 110 maternity hospitals, we still need to spread the 39-week project out to the remaining 80 hospitals, as well as package up the antenatal steroid best practice bundle. The NEO group, probably starting in the spring or summer of 2013, is going to be looking at neonatal abstinence syndrome. Michelle Walsh, our NEO lead, has some different funding from the state and is doing a pilot project on addicted infants who get care at the 6 children's hospitals across the state, and they're collecting a lot of clinical data on the infants and also testing some best practices of how to care for the infants as well as the moms. So that once her pilot project wraps up, then we will probably be using the OPQC infrastructure to get those best practices in a QI format out to hospitals across the state. And then the OB project, Dr. Imes and his clinical advisory group are working on a key driver and some preliminary metrics for their progesterone for women who are at risk of preterm birth. That's either 17P or other forms of progesterone administration. And once the key driver and measures and our antenatal steroid project all get wrapped up by the end of 2012, we'll probably kick this off again in early to mid 2013. So we always have our eye on the prize of how to improve birth outcomes across the state, and have a couple new projects that are percolating that we're really excited about. So I think hopefully between our 2 examples, both the Ohio Perinatal Quality Collaborative and the New York State Perinatal Quality Collaborative, that you've gotten an understanding of some of the methods and some of the partners and some of our results, and that there really is sort of a national movement of looking at how to continue to improve perinatal outcomes in terms of clinical outcomes, better experience for families and infants, and certainly reducing the cost of prematurity. So we've talked about our
projects, there's always continued room for improvement. I don't think we're ever quite finished. There's always sustainability and spread to other hospitals, developing other projects, making sure that what we've done over the last 2 or 3 years continues to stay in place. And I think that's the end of the formal presentation from Marilyn and I think the intention is to open up for any questions or discussion points.
At this time, I'd like to ask the operator to open the lines for questions.
Once again, to ask a question, to press star, then 1, and please be sure to record your first and last name. Again, to ask a question, to press star 1 and record your name. One moment.
Hi, Kibo. This is Kristen from New York. We have one question in the chat. It says, you mentioned that maternal education, RE preterm birth, was improved by about 53%. Please elaborate on how this outcome was measured.
So this is Marilyn in New York. The way that we look at this with our facilities is that we look at the percent of women that are informed about the maternal and fetal risks and benefits of scheduled delivery, so that there has to be a system in place when the mom comes in to deliver or is for scheduling, that they ask the mom if she has either been educated, or they design some process to figure out if the mother has been educated. I think the difficulty with this one is that the documentation in the chart isn't always there, because a lot of this education will happen prior to the mom coming to the hospital. So I think that's one of the issues with improving this measure. It's a lift, and I think that facilities are concentrating on this, and we will be concentrating on this more in the future. And I have to say that I think that everyone thinks it's important, but I think everyone is struggling with how to do it the best way.
There are no questions on the phones at this time.
Are there any other further questions? Okay, if there are no further questions.
We do have another one here.
Okay.
It's from Jeff Gould, and he says, how is data collected in New York?
And it depends on the project. So with our obstetrical project, we initially began with a data collection tool that was installed in each of the RPCs, because when we looked at our birth certificate data, we did not have enough of the fields in there in order to really say one way or another whether something was truly medically indicated or not. So we developed a new tool, and now that is a web-based tool as we are rolling it out to all the hospitals in the state. As far as our neonatal project, we have a neonatal intensive care unit module within our statewide perinatal data system that has been in place for years, since 2003, about 2003 or 4, and that neonatal intensive care units are mandated to enter data into that. So that's where we follow our neonatal measures, as well as now with the CLABSI, part of that information is also coming through the NHSN here at the state.
Are there no further questions?
There are no questions on the phones.
Okay, thank you. We would like to thank Marilyn Kasika and Barbara Rose for giving us an excellent introduction to the work of Perinatal Quality Collaborative. We would also like to thank you all for participating in our webinar, Perinatal Collaboratives 101, and invite you to join us for our next webinar in December on quality improvement principles and getting started. We hope that the webpage and this webinar series will facilitate exchange of information and promote visibility of perinatal quality improvement activities throughout the country. To help accomplish these goals, we plan to list active collaboratives and provide contact information and links to their websites on our webpage. We encourage you to visit the webpage and submit information for your collaborative if you would like to be included in this effort. You can contact us at the DRH info link at the bottom of the webpage. Thank you again, and have a nice afternoon.
Thanks, Kiba.